Sir, can we start, sir? I will first give you an introduction.
Okay, no problem. There are only 11 participants. There may be others without numbering here, right?
Yes,
okay,
sir.
we can start.
So, thank you, sir. Greetings, respected faculty members, seniors, and friends for the 7th NSSI webinar. Today it is on split cord malformations and it is being given by none other than Professor A.K. Mahapatra, sir. Sir doesn't need any introduction and is probably the most learned person in the field of pediatric neurosurgery. He has been the chief of CN Center and Dean Academics at AIMS Delhi, and he is presently the Vice Chancellor of Shiksha Anusandhan. He has written numerous textbooks and articles in neurosurgery and particularly in this field, and we are very grateful to him for delivering today's lecture. Thank you very much, sir.
Thank
Today
you.
Sir,
Can I start?
Sir, just a minute, sir. Today we will be also having two eminent pediatric neurosurgeons, Professor Dev Pujari sir and Professor Sandeep Chatterjee sir, who are also very experienced in this field and have written extensively on this topic. We also have with us Professor Devin Purohit sir, Dr. Anup Singh, and several others. Thank you very much. I also welcome everyone who has joined here, and this is also streaming live on YouTube. Without much ado, I request Mahapatra sir to begin his talk. Sir, over to you, sir.
Thank you very much. Good afternoon to everybody. I think it's very important aspect that we have started webinar in NSSI. Also, NSI also have webinar. If I remember when I joined neurosurgery, there are less than 100 neurosurgeons. Now we have 4,500 neurosurgeons in India. So the neurosurgical specialty has improved. And when we are the resident, the CT scan had just come in 78. So we had no other investigation than myelogram and X-ray and tomograms. So that time, all the pediatric neurosurgery cases used to go to pediatric surgery. They used to run a spina bifida clinic and also a hydrocephalus clinic under Dr. Upadhyay, who was the known pediatric surgeon at AIMS. But when I joined, few cases started in 1980s, and slowly the number picked up, and we have operated large number of spinal disruption. Time came when I was only operating 4 times a week, only spinal disruption and meningocele encephalocele. So today our topic is split cord malformation. Without any detail, we know that pathogenesis is all related to embryology. There are many hypotheses for spinal disruption. The most famous hypothesis is the persistent neuroenteric canal. If we look at before the Planck's hypothesis, it was all the hypothesis given by David McClelland, and this is the subject we started first, named in 1996. That is the time it was told, Bruce told it, diplomylia and diastomatomylia. But over the years, when the pathogenesis and embryology were more understood, in 1992, Dr. Pang gave the title called split cord malformation. That means spinal cord is split to 2 types, by type 1 and type 2. In type 1, there is a bony septum which is going and dividing the neural tube 2 halves with 2 separate coverings. So there are 2 types of cords. There is a full dural sac. So it is a type 1 split cord malformation. When there is a type 2, there is may not be a bony spur, but there is a fibrous septum which divides the spinal cord 2 halves. So there is a single dural tube, a fibrous septum, and there is not a bony spur. These all start in the embryogenesis, because if you look at the embryogenesis of stage 1 to stage 6, there is a first 2 days stage 1, 2 to 5 days stage 2, 5 days to 12 days stage 3, and the neural tube is formed from the blastula, neural streak and neural canal, and neural groove and neural canal. At the age of 21 days, 22 days, anterior neurospore close, and at 25 days, posterior neurospore close. During this embryogenesis, there is several phases which comes and goes very rapidly, like the neuroenteric canal, which appears in 15-16 days and disappears. If there is a persistent neuroenteric canal, which joins from the yolk sac to the embryonic sac, that persistent neuroenteric canal causes the splitting of the spinal cord, And when the spinal cord is divided to two halves, then the bony part and mesenchymal part also comes back after that. So there are many hypotheses, but most recently accepted, most generally accepted hypothesis, Pang hypothesis, but that cannot explain all type of split malformation, because if there is a semi cord or partly bony and partly cartilaginous, that is what is called 1.5 split cord malformation. That means spinal cord is half split and half one. So one is complete, half of the spinal cord is complete, and half of the spinal cord is incomplete. So that is called type 1 and 1.5 split cord malformation. This was started in about 20 years back. People started talking 1.5 split cord malformation. It is very important for all of us because in India, neuralgic defect is still common. It is about 30 to 40 cases for 10,000 population. So we still have minor to moderate form of split spinal dysraphism. If we talk about spinal malformation, congenital spinal malformation, one third are lipoma, one third are split cord, and one third is purely meningomyelocele without having lipoma or without having split cord malformation. So this split cord malformation is a very important part of spinal dysraphism, which is embryologically start during the phase 4 and phase 5 and phase 6 of embryogenesis, that is between 16 days to 25 days, when the neural tube is getting closed. That is the time when there is some neuroenteric canal persist, then that is lead to a split like spinal cord. Could be fully split, partial split, with bony septum, partially bony septum, or partially fibrous septum, all these combination there. This happens in 1 in 5,500 live births. In India, because we do not torment all these malformations, we still have large number of spinal dysraphism cases. I was used to see about 300 cases at Delhi every year. I have operated here about 40 split cord malformations in the last 5 years. So amongst about 150 spinal dysraphism I have operated, roughly about 15 to 20% split cord malformation. And here, the reference are not like AIMS Delhi, where all of northern India people used to come. So I am now operating 4 to 5 cases per year. Earlier, I used to operate 25 to 28 cases per year. So over the last 30 years or so, I don't remember any case assisted during my residency. That is between 79 to 82. When I was a resident, I think I didn't assist any spinal dysraphism. They're all going to pediatric surgery. So this is all cases. Around 600 cases I have operated last 35 years or so, both at AIMS Bhubaneswar, now here. Of course, here I have operated 40 cases, which I'm not including. So we all understand Pang hypothesis. This is persistent endomesenchymal tract. We say that during the embryogenesis, when the yolks are connected to amnion, that is replaced by a endomesenchymal tract that gives rise to split notochord and split neural tube. And when the neural tube is split, there is two cords. When the notochord is split, there is a bina bifida, and there may be mesenchymal component which comes between the split cord, the split neural structure, and that lead to a bony or fibrous septum. But Pang's hypothesis cannot explain everything. So we think there must be much more thing than only Pang's simple hypothesis. Because so many people have tried to give hypothesis that currently I think Pang's hypothesis is the most scientifically accurate hypothesis. So if we look at that, it could type 1, type 2, there could be type 1, type 2 combined, there could be posterior spur. When I wrote the first paper in 1998, the spur arising from the inner surface of the lamina and spinous process. That time, there was no report of the posterior spur. We thought that is not explained by the Pang hypothesis. There is no spina bifida, but there is a split cord spur arising from the posterior surface of lamina. So there could be type 1, type 2, type 1 and 2, and posterior spur. And then now we are talking type 1, 1.5. 1.5 means partially split cord and half of the spinal cord is one, and half of the spinal cord is divided to two halves. So we have this type of cases. I think in my experience, about 600 cases, around 55 to 58% type 1, type 2 is about 40%, and 2 to 3% complex. They may be associated with both type 1, type 2, or type 1.5, or complex types malformation like spinal type 1 lipoma, type 2 lipoma with lipoma with split cord, lipoma with neuroenteric cyst, lipoma with conus or phylum lipoma. So it is not a simple type 1 or type 2. They may have complex association of other spinal malformation or even congenital malformation of other system like septal defect, arterial or ventricular septal defect. They may have a urogenital abnormality, kidney abnormality. So in our series, in our 500 cases, 15% can have one kidney small or the kidney lying lower than the normal position. And we had about 5-6 cases of horseshoe kidney. So it's a rare, we understand it's a rare condition. It is one in about 6,000 like that. Only few large series. I was looking at the series. The largest series, if you take out all publication from AIMS, will be somewhere of 50 to 60 cases, not more than that. And we have several publications from India, from Bombay, from Calcutta, from Bangalore. So we still have publication on spinal distress from India, but we do have the largest cases in the world because we have over 500 to 550 cases. There's still a lot of controversy. Controversy is that should you operate them when they're asymptomatic? Should you investigate when they're young? If a child come with a small lipoma and you investigate to find a split cord, are you going to operate them when they're very young, less than 3 months old? So still there are a lot of controversy. Controversy meant how to operate, when to operate, how much to remove, and whether you have to use high-speed drill in a very young child. All these things because high-speed drills sometimes generate heat and unknowingly damage the spinal cord, which is very delicate in a small child. So this is what is Planck's hypothesis, endomesenchymal tract, which communicate to yolk sac to this, and that persistent neuroenteric canal or accessory neuroenteric canal can give light to Planck's hypothesis. We sometimes feel that all type of split will not be explained by Planck's hypothesis. So this is accessory neuroenteric canal. What is the clinical evaluation? It's a complex process, so we have to have a clinical evaluation. See, is it one split or multiple split? What is the type of split? What are the different association? Other spinal malformations, either a single site or multiple site dysraphism. Evaluation of the urogenital system, the evaluation of cardiac system, because we still have situs inversus. Suri and myself wrote 4 or 5 cases situs inversus. Liver is lying on the left side and spleen right. So kidney is lying on the liver lying, spleen lying in left side. So this type of problems can be there. So these cases are very important to properly evaluate. Some time back we are doing also visual sensory evok potential, but then we found sensory evok potential so fallacious. It is fallacious in false positive, false negative amount of 30%. So we don't do any electrophysiology pre-operative or intraoperative. So the question is that why do you operate split cord malformation? Because they are triggering of the spinal cord, and the commonest site is dorsal lumbar area between D10 to L2 or L3. About 60% will be dorsal lumbar area, and few of them will be L3 down, L3, 4, 5, and few of them also thoracic. I had seen in last 6 years 3 cases of cervical split and split with the of the middle oblongata. So we had a patient who was split cervical spinal cord with split medulla. So they may have a pyramidal nerve root, intradural lipoma, dormal cyst, neuroenteric cyst, dermal sinus. All permutation combinations are possible, so that one has to evaluate what are there in the spinal cord, single level, multiple level, anterior spur, posterior spur, or type 1.5 type. these people sometimes may be asymptomatic, and that creates problem. We should operate them or not operate them. I believe all patients of spinal disruption should be operated before they deteriorates. Because once they deteriorate, we may not be able to give them 100% chance of recovery. So recovery only occurs about 50% cases, and 40% remain static, and 10% may deteriorate. So that is the reason in asymptomatic cases, still controversial, should go for a prophylactic surgery or not. In my hand or in my experience, I give them a chance of deterioration 5%, and tell them if you follow too long and you do not come in the early symptoms, they may further deteriorate and they may not improve completely. So I always advise prophylactic surgery. So why do you operate? We operate for the neurological deficit to improve or stabilize and not further deteriorates. So there is a 40% people will have motor deficit in the lower limb. Sometimes we will see the zero power in the ankle joint, and there may be asymmetrical motor weakness, thinning of the thinning of the thinning of the lower limbs, and also asymmetrical motor and sensory involvement. They may have about 20 to 30% cases of bladder incontinence, fecal incontinence, uh, um, and repeated urinary tract infection. I know a lady, 25 years lady, used to come with repeated urinary tract infection, and there was no outward any spinal evidence of spinal dysraphism. But when we have investigated, there is a type 2 septum, and we operated her. That was about 20 years back or so. Next talk. Okay, so we have all patients over 550 cases or so. Their range can be 3 months to 47 years. One can ask me, why did you operate them at 3 months? If they're associated with a meningocele impending rupture, or there's a large lipoma associated, which prevent the child to be able to sleep, and the difficulty in feeding the baby. So we have operated few patients below the age of 3 months. But what is more interesting, the people come late at age of 47 years. So it is a very wide range, that age range from 3 years to 47 years. And mostly they should have come before 2 years, but surprisingly, only 45% patient came before 2 years. It is sad that people have defect and they don't come from management at early age. So the average age, mean age was 8 years, and we have more male than female. Even though literature say there are more female, but we have seen more male. So 68% has had problem at presentation. Commonest skin malformation was a tuft of hair. This is a telltale evidence. If there is a hypertrichosis, you can always suspect there is a underlying split cord malformation. So this baby is an ideal example. When the baby comes like this, we should suspect underlying split cord malformation. So there are stigmata like other stigmata. There could be scoliosis, a deformity of limbs, lower limbs, shortening of the limbs, callus equinovarus, sensory motor deficit, trophic ulcer. As the patient for any condition come late in our country, many patients come when they have foot ulcers, non-healing ulcer. They come only for non-healing ulcer. When we investigate them, they have got split cord malformation. This is what happened. I remember 2, 3 cases. They went for scoliosis surgery in orthopedic. When they are doing scoliosis surgery, they deteriorated, and they never investigated those days for spinal dysraphism. And when their paralysis set up, they went for MRI and found the split cord and scoliosis. So they could have subcutaneous lipoma, hypertrichosis, dermal sinus, midline dimple, hemangioma, nevus. All these possible things are there as the cutaneous marker or genotype of spinal dysraphism. The commonest area is D10 to L2, but they should have some dorsal, very, very rare, and lumbosacral area also. I told you about 4 to 5 patients are cervical in location. This is one of the cervical split, got a very short neck and spina bifida and cervical region, and also a split cord malformation. So nowadays, we, of course, don't do plain X-ray, is not required. We sometimes do CT scan because one can ask why CT scan. CT scan takes very short time and it costs both MRI spine head will cost more. So sometime in the back you used to do head CT. Nowadays, of course, you don't do head CT or CT spine. The only thing is to do MRI of the whole spine. Unless you do whole spine, we can miss multi-site spinal dysraphism. About 10% cases can have multiple site spinal dysraphism. One split cord, another case, neuroenteric cyst, or there could be lipoma, conus lipoma, something like that. So you always go for the caniospinal screening. Neurophysiology, we used to do the spinal sensory evoked potential, pre-operative and post-operative if the person deteriorates. Nowadays, of course, I don't do spinal. When I even towards the end of my career at AIMS, I never did all these investigations, small kids, not necessary. Intraoperative also, I never monitor small kids. If it is above 5 years, it's easier to monitor them. Kidney function test, very important. We did 100% cases of MCU and urodynamics and also radioisotope study of the kidney to see size of the kidney, location of kidney, and kidney function test at their GFR. So it is very important to understand, otherwise post-operatively, the relative will blame you that something has gone wrong in the kidney after surgery, which is not correct. So we should all investigate. These are not emergency surgery. So we must investigate it for urodynamic studies, urogenital abnormalities, which is associated about 15% of all these patients. So why do we surgery? What is the rationale of surgery? To prevent the damage of the further damage of the spinal cord. If we do not do anything, some people may not deteriorate till the age of 20 or 15 or something. When the rapid growth of the spine or when the height of the patient goes rapidly, that is the time they may deteriorate between 15 and 20 years of age. But some people still came to us with no neurological disorder, but urinary symptoms, recurrent urinary infections. So for investigating urinary infections, we found there is split cord malformation. So all these things to be kept in mind, and they should be operated before they have very severe deterioration. Why MRI? This is the best evaluation for the spine, and we do not want to expose the radiation exposure to child who are growing brain and spinal cord. So it is also important to understand because a split cord, many of them will have type 2 carry malformation. So they have Sarsu kidney, single kidney, small kidney, polycystic kidney, ectopic kidney, hydronephrosis. All these things are possible in a patient with split cord malformation. We should not overlook these urodynamic studies. A lot of patients are operated AIMS Delhi. I also operated Sanjay Gandhi. I operated AIMS Bhubaneswar. Now I am operating here. Of course, here I have not included about 40% which I operated last 6 years or so. So long vertical incision. I always prefer vertical incision so that you have a long exposure of normal spinal cord. You can see the conus, you can see the normal spinal cord, you can see the phylum if possible. The phylum is also have got lipoma. So it is conus and filar lipoma combined. Then it is also phylum lipoma should be excised. So I do always laminotomy above, 2 segment above and 2 segment below, so that that wide exposure and I fix them with either glue or the most likely glue. See the question of what happens? Why do you operate? We operate them to see that they improve or they remain stabilized so that there is no further deterioration in the future. That is why we operate them so that they can remain stabilized or improve. Most importantly, preserve the motor function, autonomic disturbances, and kidney infections. So we know that in large number of cases we've studied, the trophic ulcer healed about 40% cases, improvement occurred around 50% cases, but trophic ulcer only healed in 40% cases. About roughly 5 to 10% patient can still deteriorate it because in these cases, learning curve may be very long because you do not get those many patients unless you operate 30, 40 cases, you will not get very much confidence. So when I operated 1980s, mid 80s, it was very, very scaring to operate them when there is no facility those days, no midazolam drill, no monitoring, no anesthetics, which is very good monitoring, anesthesia monitoring. So it was difficult. So wound infection, what are the complications occur? Complications mostly occur the wound infection because these children are small, they left in the bed, the wound will be soiled with fecal matter or urine, all these things. So it's very important to see that the children are not in a prone position or lateral position. Most of the time, all these babies are left in lateral or prone position, and head is slightly tilted down so that if somebody also pass urine, it won't soak the sacral area. It will come down to chest and abdominal area. So it is very important to understand. UTI is very common in these children. Even after operation, one has to repeatedly do the investigation for the urine culture because they may be asymptomatic. They may not tell that they may passing frequent urine, but they won't tell the urinary tract. Classical urinary tract infection with pain, burning may not be there. So it is very important. Sometimes actually it is not true. We have re-explored in split cord about 4-5 times. I know that 3 of our patients have regrowth of the spore. If the spore is remain, the base of the spore is still remaining, sometime they may regrow. So regrowth, we have written, Suri and me, and Dr. Deepak Gupta and me wrote 2 papers. Regrowth of the spore. The spore was removed and the patients are okay. After 4 or 5 years, the spore regrew and we operated. So these things should be kept in mind that the spore, base of the spore can regrow and can produce symptoms again. So what is emergency? If a person comes with SCM with a leaking meningocele, SCM with a large lipoma, and it's very difficult for nursing the baby, so you remove the lipoma and also you do the remove the spore. Sometimes person comes with repeated urinary tract infection and you investigate, and to prevent that you can go for investigating them and operate early. So even though I don't operate before 2-3 years of age, I still want that if the patient needs early operation, like a recurrent urinary infection, leaking meningocele, large lipoma, we can operate less than 2 years of age. Some patient can hydrocephalus. Around about 10%. In split cord, it is not very common to us hydrocephalus, but split cord with lipoma, split cord with meningomyelocele, definitely they will have hydrocephalus, and I put the shunt. Either I put the same sitting sound fast, then I make the patient prone and operate. In early phase, in 80s and 90s, I used to operate 2 sittings. Fast is sound, and after 4-5 days, I operate them for the spinal dystrophy. Now, because anesthesia is good, ICU is good, monitoring is good, we can take the liberty to do one operation because at AIMS Delhi, to have repeated admission for a patient when the waiting list is 2 to 3 years, very difficult. So I operate them in one sitting. The aim of the surgery to prevent damage, stabilize the condition, and improve the existing deficit. This will going to happen. So patient is going to happen around 45 to 50% case. We will have stabilization another 45%. 5 to 10% patient can still deteriorate. So one has to take all this with careful so that you drill very carefully and put lot of saline. If there is hitting of the tip of the bore, to give a pause and see that it would take more time than quickly removing the spore by drilling. So it is very important to understand at a small child, even the drilling and generating heat can damage the very developing young and delicate spinal cord. So we have more than this is a small series we published, Sachin and myself. So there are neurological deterioration as 5%, CSL with 10%. Overall, if you have big series, your complication rate will come down and you will have more experience. But CSF leak is always there. You have to meticulously close the dura, and dura is not very elastic, so even the needle hole in the dura can produce it. So after completely closing the dura, I sometimes use the tissue glue and see that the suture line is covered by tissue glue because I have seen after complete dura closure there is CSF leak. This is a child. Of course, everybody has now seen this children operated. So, in this was the paper we had written 2012. That is the time Sachin analyzed for 2 years. In 2 years' time, we have 51 cases of split cord malformation, and that is the time when we had 150 cases of spinal disruption operated in 2 years. These are few diagrams I have done. We have also, these are diagram, partial split, complete split, posterior split. This is one of the example of posterior split, where the spinal cord is not completely split, is 1.5. It's a posterior spur. Spur is based posteriorly. It is not reaching the posterior surface of body. Spinal cord is partial split. Septum is partial bony. So it's 1.5 split. And I have seen the oblique split. All type of split is shown here. Oblique split, posterior split, partial split. This is a large bony split. One have to understand sometimes the base of the spur is attached to 3 or 4 vertebral bodies. Could be about 2 centimeter, 1.5 to 2 centimeter thick. So very carefully one has to remove with a micro punch and very small diamond drill, and giving a lot of pulse so that it doesn't generate heat. Should you operate paraplegic? I always operate paraplegic because I know that even if you do operation, there may be small percent improvement. If there is paraplegic with split cord and large lipoma, the lipoma removal will help the baby to be nursed by the mother. Breastfeeding will be easier, and all these things are very philosophically important for the family. We always use microscope. I use drill, laminotomy, and if the lipoma, we used to have vaporizer and laser doses. Nowadays, we don't. I always prefer to have durography. Dura is short because it's a wide split. After the end of the surgery, there will be a big split because you are converting 2 dural tube to 1 dural tube. So I always take the fascia lata or lumbar fascia and stitch it, properly stitch it, continuous suture 5060, and I try to complete a complete dural closure, and then I put glue. Motor improvement, this series with Sachin and me, 38% sensory improvement, 40%, autonomic improvement only 25%, trophic ulcer also healed. So we have to see that we never expect improvement more than 50%, and we also always should tell the relative chance of deterioration between 5 and 10%. We should not underestimate the surgery because once deteriorated, you tell them, they are not going to accept. So it should be always careful to tell all complications before surgery, once, twice, thrice. I always talk to them 3-4 times in 2 days' time so that they understand the implication and seriousness of surgery in a child who is 3 or 4 kg weight and 6 to 8 months old, and you have to operate them for large lipoma with split cord. So these are the complications I have already enumerated. Proper evaluation, early surgery, surgery for asymptomatic cases, a regular follow-up, reoperation of refiguring or scoliosis or regrowth of the spur. Bang hypothesis, we always contradicted him. We say that all type of cases cannot be explained. I cannot also explain by one simple hypothesis all type of split cord malformation. So we still have controversy in pathogenesis of split cord malformation, which cannot explain all type of spinal dysraphism. I think these are the many cases. This is a wide split, big thick spur. You can say how wide is the spinal canal. Multiple split, 1, 2, 3, three places different problem. Kunal, this is actually I classified the type 1, A, B, C. If the bone is septum is in the middle, is type A. If that the top of the split is type B. If the bottom of the split type C, and if the split is covering whole gap, type D. So this classification I myself made in 2005 for Dr. Mahapatra and Gupta classification of type 1 split cord malformation. These are few cases. I don't want to. So when we have analyzed 400 cases of SCM, that is the time we operated 1500. So roughly 25 to 30% cases of split cord, 250 lipoma, they have dermal sinus. So from 2000 till 2010, we had 400 cases of SCM. Now, of course, in last 10, 12 years, we have more than 150 cases. Overall recovery 50%, stabilized 45%, deterioration 5 to 7%, non-healing ulcer heals in 40%, re-scissoring we can have about 10 to 15%. So I think controversy, operate paraplegic or not, urodynamic study in children, necessary, not necessary, operation in asymptomatic case or not, extent of removal of lipoma or lipoma so split cord, how much lipoma in the split cord you remove fast or lipoma remove fast, or both are to be done in the same sitting with a long duration of surgery. So I think in a nutshell, in last 30 or 40 minutes, I've talked about what is split cord, what are type of split cord, what is tying hypothesis, what is the embryogenesis, how it started from the blastula, morula, then neuroentry canal, disappearance of neuroentry canal, between 16 days to 25 days time. If there is a persistent neuroentry canal, that will call the split. Subsequently, mesenchymal element will come and on the bone. So we know that split cord malformation is not a very common condition. However, considering India's vast population of 1.5 billion, we still see 20 cases, 15 to 20 cases per year. After coming to a small place like where I'm working now, I have operated 42 or 43 cases in last 5, 6 years. So instead of operating 25 cases at AIMS Delhi, I'm operating 6 to 7 cases per year now. So I think we are our students are our residents very smart. The younger generation know much better microsurgery. We have better facility and better anesthesia, better ICU. So we think we should all operate them at every places. We don't require to send them to big centers and a senior neurosurgeon. We can all operate them. So it is a condition which is still prevailing rampantly in India. I think all of our colleagues, Dr. Depujari, Dr. Sandeep Chatterjee, or Bangalore, or Hyderabad, Trivandrum, everybody sees spinal dysraphy in large extent. Even though the incidence has gone down, considering the less number of people operate the small children, we still have large number of patients referred to bigger center for better facility. So I think we all should teach our residents, they should deal with children, manage spinal dysraphism, see that they can do their best, and if they require further training, they can go to different centers of India for practical experience so that a high volume center like Nimhans, AIMS, Trivandrum, or Bangalore or Vellore, where you see that 100 cases of spinal dysraphy operate every year, so that 15 to 20 or 30 split cord are there. So if you go to a high volume center for 3 months, you can have a better experience in this condition, which is otherwise not very common in smaller maybe medical college level. So I believe for the better pediatric care of our children, many of our students should go to different center for further study. Thank you very much. I think we have another 20 minutes. We can have question answer.
Thank you, sir.
Jatin,
Thank you, sir.
I think I finish in 40 minutes.
Sir, thank you, sir. Thank you for such an enlightening lecture, sir. We have two questions, sir. The re-teethering of the cord is a very frequent problem, sir. How do we prevent the re-teethering of the cord after the surgery?
I think when I operate, I always cut the phylum, because if you're operating and not removing phylum, and phylum is thick and start, and the conus is at about L3 level, they always produce problems. So first thing I say, re-teethering or incompletely untethered. So if are not completely untethered, they put a thick phylum. So when we operate, we should see the all extradural bands, intradural bands, and there are redundant nerve roots, extra nerve roots, and median nerve roots, because there are large number of tethering element in the spinal dysraphy. So we should properly investigate so that you have not missed another split somewhere or another spinal. So you should see our entire spinal axis. You have operated in the conus lipoma, conus split, or at S1, but there is something at D11 or D8 level, multi-level. So when you are operating this child, see the evaluate entire spine and also the posterior fossa, so that you are not missing the multiple site of spinal dysplasia. Yes.
Thank you, sir. Sir, one more question, sir. How important is folate supplementation, and why our country is not having?
I think it is very important to have folate. Yeah, if you know that Dr. Yogi Patisapu is all the time coming, and Indian government, they have gone many times. They have gone. Dr. Kale and I think Sandeep Chatterjee, Dr. Kale, maybe I don't know Shekhar had gone or not. When Dr. Yogi comes, he goes to the ministry and talk about folate. You know, it is very difficult to convince Indian government. They don't have an advisor. Our advisors are IS officers. I stayed in Delhi. They never talked to us anything about any neural condition, whether Savarkand hemorrhage. I don't go and sit in the ministry. I will be their advisor, because many people run to ministry to become an advisor. I never did that. But I think if the government doesn't want it, they are sure, because these young IS officers and ministers are knowledgeable. They know this. And Dr. Yogi has been writing to Minister of Health for last 10 years. I am hearing. I think sector knows it. But I think they are trying to implement. When I go to Delhi, I hear that now that fortified atta will come with all this folate. I think that is very important. But we should give enough folic acid during the pregnancy, before pregnancy, or in expectant mother, those who are just newly married. If they are given proper nutrition, that's okay. It's educated the public. That is very important.
Thank you, sir. Thank you. I request Shekhar sir to give his comments, sir.
Sorry, I have not been able to attend the full lecture, but I have heard Dr. Mahapatra several times with his excellent talk on this split cord malformation. And he has the classification he has created is also very important for prognostication and need for surgery, etc. The last point which you talked, I will take up first. I think there is a more and more awareness about folic acid today. But I had one question for Professor Mahapatra. Do we know enough that folic acid supplementation can prevent probably spina bifida aperta or open defects, that is myelomeningocele? Can it prevent closed spinal defects as well?
Actually, I will not be able to tell that unless we go for the prospective study that how deficient folate in the closed spinal dysplasia, because these are all evolving. We have been talking, if you go back to 50 years, when the spinal dysplasia rampant in the Europe and America, they also not talk about folic acid. And in India,
Absolutely.
I think the folic acid deficiency is not too much, I suppose, because a lot of people take SAG and other vitamins. So that
the
is not
Canadian
the
study has shown, as you are aware, Professor Mahapatra, that it has been able to prevent fair amount of myelomeningocele, but it has not been so successful in preventing spina bifida occulta. So that is
quite
something
possible. I say unless we have enough data, have evidence, but we know that folic acid is one of the cause of neuralgia defect. So it's a open or cause, how severe will be problem, how many percentage people have neuralgia defect. But there is no doubt that folic acid supplementation, that is one parameter. There is also genetic parameter, there is other nutritional parameter, protein deficiency, calorie deficiency. It is not only one deficiency of folic acid. So I think folic acid is an important factor, but not only factor. I'm sure your Canadian study, Dr. Paul has been talking so many times. You have heard about Yogesh Bhattacharya. He runs from any place to other place. He said,
Dr. Sandeep Chatterjee, is he with us? He has recently reviewed a lot of literature. Is Sandeep with us?
Yes, sir, he is joining. Sandeep. I don't think, sir, he is not here.
I think there are only 21 participants in my screen.
The second question, as you said about tethering, I think many of SCM2 patients have associated, low-lying. So
Conus,
what is your
conus.
general, low-lying conus and many a times even fatty phylum. So what is your general sort of advice to people about SCM2, where sometimes you are not sure you should operate or you should not operate?
Actually, Sekhar, I operate everybody because I want to see many part of the tethering may not be seen, like bands, dural bands, accessory nerve root, median nerve root, because so many factors which cause the tethering. It is not only the bony septum or fibrous septum. Even you see a normal lying conus. I don't know whether you remember, Paul used to tell in case of some spinal dysplasia where only urinary incontinence, he went and caught the phylum. So I think we are not able to visualize all part by MRI. Many things which you see during operation is not visible in MRI. So MRI only give us the software component and CT gives about the bony component. But anything which is less than 1 millimeter thick but can tether the cord is not seen. So when I open the cord, I see cord all around, any strand, any arachnoid bands, anything like that, or median nerve root itself. You know that median nerve root can hold on the spinal cord also, right? Tethering the cord. So all median nerve root are extra and superfluous, non-necessary. We just got them, no problem. I per se propagating in my place. I was at AIMS that all spinal disruption like split cord or lipoma should be operated, because if we do not operate, the deteriorate don't come back. Because you know that not many specialized centers do it. Even though we have large number of people doing pediatric neurosurgery, they are scared to deal with children less than 2 years. You understand? So they will be telling just wait and see, it may stabilize. Why are going for surgery so quickly? Let us wait for 5 years or so. So I think these are not right advice to the parents. If I have the chance to operate a child at 1 year, I will not ask him to wait for 5 years. Because after deterioration we operate, we are not sure about more than 50% sure of improvement. So I will say I'll give you risk of deterioration 5%, risk of improvement 50%, 40% chance of stabilization. The parents have to decide, because they are here. We can only give the option. The choice is the parents, right? I never force a operate patient on to get operated, because they are small children. You know that. Sometimes there may be only 7, 8 kg babies, small babies.
Thank
So,
you, Jitin, for this
yeah,
opportunity.
so there are some questions.
Yes, yes.
First question is from Dr. Hitesh Gurjar. How to minimize blood loss during SCM surgery?
Actually, there is only one blood vessel which goes to the septum, if a bony spur. And if you carefully drill and see that point is bleeding, that is the point where there is a little bleeding from the artery going to the septum and coagulate that. I don't think uh, if there is no lipoma, there is no other association, split cord alone will not require blood transfusion unless child is having blood hemoglobin less than 12. A child who is less than 2 years should have hemoglobin 15 or 16. If he is about 10, 11, we think it's 10 is normal. So if a child of 2 years of 10 or 11 hemoglobin, I start blood during anesthesia. So I know that he is anemic for his age, not for my age. Okay. So only for removing a split cord, there should not be requirement blood if the child hemoglobin is 15, 16, 17. Not necessary. Lipoma can bleed. Lipoma bleeds a lot and not the split cord.
Thank you, sir. So, what type of shunt pressure Dr. Datta is asking?
What type of?
Shunt pressure, low pressure, medium, high. Which
I always put low pressure. You see, we had done a study in 90s, if you remember, ultrasound. And that time they were only giving medium sound to the small children of less than 2 years children with acute stenosis. All of them failed. So we cannot put a medium pressure sound in a child, because for a child, even 10 millimeter of mercury for a growing child is high pressure in the fontanage open. Many children come below 2 years. They have spinal dysaphysium, little pressure in the brain, ventricles are large. We say, okay, nothing is necessary, but I put a shunt. And these are low pressure shunt. Okay.
Thank you, sir. So Dr. Morata is asking, neuroenteric canal is formed early in the stage of spinal cord formation. Why does it is associated with the spinal lipoma or DST, which develop later
See,
on?
there is a multiple congenital embryogenical abnormality. Neuroenteric canal is one, and lipomagenesis is other. If the both pathogenesis of embryology of lipoma formation and split cord is there, they will have complex malformation. Only if the neuroenteric canal, they won't have lipoma. Lipoma pathogens is completely different. So when there is a spinal dysraphism, they may have multiple components, so that one is neuroenteric canal, other component is the secondary neurolysis and caudal cell mass and all these whatever notocaudal problem. So if you have multiple problem of embryogenesis, you will have multiple component. So they are not single one.
Sir, what are the specific measures you take to prevent adhesion in the operated site? Do you impose any fat at the drill site?
No, I don't do anything. I see that dura. See, most common cause of street feathering is dura, CSF leak and infection. And at any cost, you must see that you can remove spore in 1 hour, but take 2 hours for complete dural closure. That is more important. Because if you dura has a little leak, and sometimes what happens, your needle is making a hole in dura, and dura is not elastic. They are not normal dura, and that hole of the needle can produce leak. Secondly, we thought, okay, we will not put a patch. We try to have a tight dural closure, and that dural closure give way after the surgery. So what happens? You should see that dura is lax. If necessary, put a patch and take all meticulous. Don't give too much of gap between stitches. It is better to have continuous stitches than interpret stitches. And if possible, and if the finance help you, allow, you can put also glue. Because I have seen after complete dural closure, there is CSF leak. I always wonder, why did they leak? I think they leak from the needle. Use fine needle, 560 Vicryl, not 40 or 30. Many times we use 30, needle is very big. 40 very big. I go for 50 or 60. That needle sometimes break. It is better to lose a thread than having CSF leak and infection.
Sir, what do you do for skin closure defect? I mean, in open neural tube defects.
Actually, in open dural tube defect, I mobilize the spoon by jet plastic. Till today, I have not taken any dura or skin graft from somewhere and put it. Till today, out of 4,500 spinal disc operated, I have never required to have a skin graft from anywhere. I always able to mobilize and get it done. Okay? I don't know, Shekhar, do you have any time required to have skin
No,
graft?
first of all, I think about closure of dura. I think the only problem comes in dural closure for split cord malformation is occasionally you may find it difficult to repair the dura anterior. If you have gone all the way, drilling up to the surface of the vertebral body, and you have to remove the septum in between, then occasionally you may have problem in closing the dura anteriorly, and sometimes we just keep a graft and put glue and come out, but posterior dura is closed meticulously completely.
I never close the anterior dura because we don't go beyond the vertebral body. It is only the base of the posterior part of the vertebral body, right?
Yes.
So why should anterior dura opening? Theoretically possible, but I don't think I have seen that case. Okay. You are definitely sound rational, but how you will close the anterior dura is so much gap.
That becomes difficult.
Only thing
The
you can
second-
patch and glue.
Yeah. And the second question was about what was the second question? Closure of the skin. I think in usual split cord malformation cases, it is not a problem. In large meningomyelocele, it can occasionally be a problem, and therefore, we usually speak to our plastic surgery colleagues and decide how to incise the skin. Most of the times, if you take proper skin cuts, it is possible to repair it primarily. The most important layer to close is probably the lumbosacral fascia, and you can go right up to the flanks on both the sides to mobilize the fascia so that you can do a double breasting before you attempt skin closure. very, very rarely it happens once or twice a year that we need help of plastic surgeons to create flaps for us, which we can close on that. But it's not very common.
I
you.
had worked in plastic surgery during my residency. You can have mobilization, give the extra incision, mobilize the skin medially, then you can do that. Skin closure has never been a problem. Skin gapping can be there because the quality of the skin, the blood circulation of skin, but the closure, primary closure of the skin, you may close the skin after some time it is a gap through because the skin is non-vitalized and the blood circulation is not good. That is different. Breakdown of wound is different than the primary closure of the wound. Even a healthy skin may break down after some time because they are not vitally good blood supply also.
Yeah.
That is more so for the meningomyelin, not for split cord.
Correct.
Because split cord, if you not assume meningomyelin as normal skin with a tuft of hair or a dimple or a small hemangioma or nevus, they may not have the skin gap.
Thank you, sir. Thank you. We have no more questions in the chat box. I request any audience to ask. Varun sir, do you want to ask something? Varun sir, Purohit sir.
Yeah, Jitin, I have one or two bad experiences. I don't know what happened. Like I was doing one split cord and I removed the spur and everything. Just we want to change the position from prone to anterior and patient had cardiac arrest. And I feel that when you mobilize this, something might happen to the brainstem or something. We could not find it out why patient had cardiac arrest. So after mobilization, maybe some effect may happen on the brainstem also at that point. So I lost one patient on table after closure, just making from supine, prone to supine position. Just we were changing the position after surgery and patient had a cardiac arrest. Patient was about 3-year-old. We could not find out the reason why that happened.
Hypothermia, if I know hypothermia.
That's right. These kind of things are more likely rather than because you do not have hindbrain herniation also very regularly with split cord. So, I mean, that is unlikely that we are disturbing the brainstem.
Mm-hmm. And patient had no hydrocephalus.
Hydrocephalus also will not suddenly cause the cardiac arrest.
But this happened with my patient.
And quite possible. It could be anesthesia problem, anesthesia problem, drug problem.
Yeah, was one thing you discussed that anterior closure. Sometimes it is because child is very small. It is difficult to completely close the anterior one after releasing. It is difficult, and even if you put glue, sometimes it may leak. So that is there. And sometimes you could not clear the tethered cord. These kind of things happen practically when you are doing these kinds of surgery. And sometimes lipoma with that is too huge. So these difficulties I had during these surgeries. Just sharing that.
Actually, prolonged anesthesia can lead to cardiac arrhythmia. Small children can have unexpectedly. I have seen for other conditions. Everything is okay. Child go to arrhythmia and sudden asystole. And if you are in operation theater, you can revive them. Even just in the recovery room, they are gone.
Yeah.
Because of drug, too much of muscle relaxant, cardiac arrhythmias, hypothermia, inadequate replacement of blood, anything like that. And sometimes the drug, anesthesia drug, which drug they are giving? Have they given anything for the cardiac depression? Too much of sympathomimetic, which can reduce the heart rate. Parasympathetic.
We normally give temperature probe we put, but even then this thing happened, and this happened after closure. Skin
No,
was
it is nothing due to surgery.
just from prone to supine position, we are putting the patient.
Actually,
and patient
actually,
has
another cause is the pain. So
Hmm.
if the pain is not looked after, in a small
Hmm.
child, pain has caused a cardiac arrest
Okay.
because reflex vagal stimulation.
Hmm.
I don't know. This is what I'm thinking loudly. What
Yeah,
are the
yeah.
possibilities?
But I tried a lot to find out the cause and I could not find out.
No,
Anyway.
it's not easy to find out always the cause of the problem.
Hmm.
Thank you, sir.
Okay.
I
Okay,
request,
thank you.
I request any of the other participants to also ask. We are just nearing to the closing time. If there are no more questions, sir, shall we close the webinar, sir?
Thank you very
Yeah.
much.
Thank you very much.
Thank you, Shekhar. Thank all of you. Thank Yatin.
Thank you,
Thank
Professor
you.
And
Mahapatra.
Varun.
Thank you, Nitin.
I think very nice to talk to you on the webinar.
Thank you.
Okay.
Thank you,
Okay.
Mahapatra, sir, Dev,
Thank
sir,
you.
and
Thank
all the
you.
participants. Thank you, NSSI. Thank you, sir.
Okay.
Thank you, sir.